So I'm going to talk on first-time shoulder instability operated right away. So if you look at the background, so most of the shoulder dislocations, 98% are anterior. They occur in less than 30 years of age group, and 95% the cause is trauma, and more commonly in males. If you look at the pathomechanics, it is not anterior dislocation per se, but it is more commonly anterior-inferior dislocation because there is damage to the anterior-inferior capsule ligamentous structures, and this associated injury to the posterior aspect of the humeral head because it moves forward and leading to Hill-Sachs lesion. It occurs because the scapula is away from the thorax, its resting position is upwards, internally rotated, and anterior tilt. So the main kingpin to restrict the shoulder from dislocating is the labrum. It is the thickest, rounded convex bumper integrated into the articular cartilage. It increases the depth of glenoid by 50%. Labrum, along with the IGHL, takes up all the compressive forces. Once torn, the inferior labrum moves medially, and the percentage of anterior labrum periosteal sleeve avulsion lesions, also known as ALPSA lesions, is very high. Shoulder stability is mainly due to concentric compression, given mainly by the concavity of the glenoid, intact capsular ligamentous complex, balanced forces of rotator cuff musculature, scapular orientation, and the versions. So what is the aim? Our aim is management of shoulder dislocation in a way that there is no threat of recurrence. There's full functional recovery, no threat of future glenoid arthritis, and there's improved quality of life. So if you look at the pathophysiology, there's soft tissue damage which leads to microinstability, be it dislocations or subluxations. This repetitive microtrauma increases the laxity, which causes progressive anterior glenoid bone defects, which results in recurrent shoulder dislocations. So where you could have primarily repaired a shoulder, you have to go to salvage procedures. So if you look at this instability spectrum, you can see in this, as the age increases, the level of recurrence decreases. If you look at the age group of less than 10, there's 100% rate of recurrence. In 10 to 20, there's 70 to 94%, less than 30, 72%, and between 30 to 40, 50%. So what if you give conservative treatment in such patients? It causes repetitive sub-failures. It decreases ultimate load to failure. It increases the capsular elongation. There's increased laxity. There's recurrent dislocation, progressive bone defects, and it increases the risk of arthritis. So you can see over here, there's a nice juicy labrum on one side and an ALPSA lesion on one side. So what does it lead to? It leads to ALPSA lesions. It leads to increased capsular injuries. You can see there's a rent in the capsule due to repetitive dislocations. There's increased cartilage damage. There's increased glenoid bone loss. The larger Hill-Sachs lesion, which requires another procedure called remplissage. And there's higher rate of glenohumeral arthritis. So what are the advantages of the surgeries? It minimizes the chances of recurrence. There's return back to pre-injury level of activities of sports. There's improved quality of life. And there's decreased risk of glenohumeral arthropathy. When not to do surgery? When patients are having epilepsy, multidirectional instability, habitual dislocators, non-compliant patients, and patients with medical comorbidities. So now I'd like to move on to the literature supporting this. In this, you can see this study. It shows that an increased number of recurrent dislocations prior to primary Bankart repair was associated with increased odds of recurrent instability even after surgery. The OR for failure or increased with increasing number of preoperative dislocations. When you look at this study, an editorial commentary by Stephen Burkhardt, none other than the pioneer of shoulder arthroscopy surgery, he says that the recurrent anterior dislocation in adolescents reveal a high rate of off-track Hill-Sachs lesion. Means when the shoulder dislocates, it engages on the anterior aspect of the glenoid. So this new information makes a strong case in favor of arthroscopic Bankart repair for adolescents with the first-time anterior dislocation of the shoulder. When you move on, this is a study on soldiers. This study aimed to report the post-operative recurrence rate in soldiers with first-time shoulder dislocation versus those with recurrent dislocations before surgery. It included 143 soldiers. So what was the conclusion of this study? Patients who underwent repair after first-time dislocation showed lower post-operative recurrence rate as compared to those who had multiple dislocations before surgeries. It is prudent advice to early repair even after first dislocation, especially in young active soldiers, to reduce the risk of post-operative recurrence. You move on to another study. This was published in European Journal of Medical Research in 2023. It's a meta-analysis. It also concludes the same thing. So surgery after first dislocation had superiority over conservative management in terms of recurrence, return to play, subsequent instability of surgery. In this article, I'll just summarize. There were two groups. One group of 25 patients in whom they were operated after single dislocation, another group was operated after multiple dislocations. So in group A, there was no recurrence at 12 months to 4 years post-op, and only 4% had little instability, and they were labeled as unsatisfied. Whereas in group B, 8% had recurrence and 10% had unsatisfactory result. The reason for this you have to consider in that is the poor tissue healing environment, what the report suggests. If you move on to long-term follow-up results, this is a 10-year follow-up result. So what did they conclude? In this, for 72% patients who underwent of primary Bankard's repair had excellent results, whereas 74% of conserved patients had unsatisfactory results due to pain, instability, and stiffness. So once you go to another study where the meta-analysis, okay, this meta-analysis had looked at 10 studies, and this is a very interesting one. You can look over here. In 299 patients who underwent arthroscopic repair, of that only 9.7% had recurrence. Whereas 270 patients who underwent conservative trial had 67.4% rate of recurrence. They also had a look at the stability. So in that, 185 out of 185 patients, only 5.9% had instability after arthroscopic repair, whereas in the conservative group of 180 patients, 46.7% had instability. So to summarize, this undeniable evidence in the form of systematic reviews, RCTs, etc., suggesting that there is unacceptable high incidence of recurrent instability in conserved patients. Progression of arthritis is directly related to instability, and arthroscopic Bankard's repair has to be offered as a routine to young first-time dislocators. Thank you.